Birth and being born brings us to the essence of creation, and wherein the human spirit is courageous and bold, and the body miracle of wisdom. But what if, after going through this laborious journey of pain and endurance, within minutes, a mother's dream and her bundle of joy turns into a nightmare? Respected audience, today I am here to speak about the obstetric anal sphincter injury, that is OAC, and its management. So these are the headings under which I'll be covering. I'll be speaking about the incidence, morbidity, diagnosis, classification, repair, prevention, and of course the key points and few take-home messages. So basically what we know, that our sphincter complex has two components, internal and an external one. Internal sphincter, as we all know, is a continuation of the rectal smooth muscle mucosa, rectal smooth muscle, whereas the external anal sphincter is striated one, and it has three components, the superficial, the deep part, of course, and wherein the external anal sphincter is embedded into the anococcygeal raphe posteriorly. Anteriorly, it is inserted into the perineal body. This pointer isn't working. Of course, where the perineal body acts as a pivot, wherein the transverse perineal muscles, the superficial and the deep, and the bulbospongices all together, they play an important role into the continence mechanism. And of course, the puborectalis, which forms a U-shaped sling. And of course, to have the incontinence in place, we need a proper nerve supply, the autonomic, and of course the somatic system also. So with this background, we'll be going to the incidence. So how often is OSS? Now, every 6 in 100 primary patients will have undergone OAC or a sphincter injury. So it depends, basically it depends on the type of episiotomy which is practiced. It may vary from 0.5 to 2.5% in vaginal deliveries with mediolateral, and as high as 11% in persons in cases where a midline episiotomy is done. Of course, in UK, there was a trial. In Indian trials are less. There was one which was done in Fernandez, which also showed an incidence of 2.9%. More so in primary, it was 6.1% and 1.7% in multi-paras. So it has tripled from around 2% to 5.9% among single-term cephalic vaginal first births. Now, with increasing training and awareness, and with increasing detection, the increasing 3rd and 4th degree tears need not implicate a poor quality care. Of course, going to the previous slide, many a times the patients are discharged and they have an occult injury which is detected on an endoanal scan, as high as in 35% of primary paras, 44% of multipara, and most of these injuries would have occurred in 80% of forceps deliveries. Now, why is it important? Of course, because it is a very important cause of maternal morbidity, most common cause of anal incontinence in women, and incontinence is definitely the worst thing which can happen to any person on this earth, especially a mother who is breastfeeding. Apart from it, the immediate complications like pain, dyspareunia, sexual dysfunction, fistula formation. Of course, the pain is due to the reactionary edema, bruising, or the tight sutures, wherein even if suturing has been done, repair has been done, but the pain has interferes with the mother's ability to and her coping up with the daily activities of motherhood. And long term, of course, a persistent pain can cause dyspareunia and sexual dysfunction. 50% complain of the above symptoms following OSS. Of course, the incontinence depends on the grade of tears, which I'll be discussing shortly. It's around, incontinence is seen with 21% with 3A, 31% with 3B, and with higher grade of injury, we have 64%. So repair of internal sphincter isolatedly has a favorable outcome in around 75% of patients. Missing a diagnosis amounts to substandard care or negligence. The occurrence doesn't. Now here we can see that there is a rectovaginal fistula which has formed, and it may be due to abscess, wound breakdown. Okay, now we'll go looking at the risk factors. Can we predict? There are any conditions where we should be cautious that, okay, this mother is likely to land up into OSE? Of course. One is nulliparity, birth weight, a higher birth weight greater than 4 kg, shoulder dystocia, occipito-posterior position, prolonged second stage. Now we can have the odds ratio that as the second stage of labor rises beyond 2 hours, the odds ratio increases. And of course, an instrumental delivery of the forceps, even with episiotomy, has an odds ratio which is similar to a ventouse delivery without episiotomy, almost similar. So ventouse is better in preventing OSE, definitely. Now, how do we diagnose? Of course, by a systemic and vaginal and rectal examination. Now, as per guidelines, we should explain the woman what we want to do, and it should be done with under analgesia, preferably maybe anesthesia also in the OT, wherein the lighting is proper, the position of the woman is so that she is comfortable and her genital structures can be seen clearly. We use our thumb and a forefinger to look for buttonhole tear in the rectal mucosa, which is usually missed. And by making a rolling movement, that can be diagnosed. Of course, few cases, around more than 33% of occult OSE are detected on endoanal USG. Here we can see lateral to the arrow mark, the external anal sphincter is the white color opaque ring-like structure, but which is missing, the continuity is missing over there, lateral to the arrow marks. So that shows a external anal sphincter deficit anteriorly. Now to classify, we all know first degree, second degree. Of course, OSE encompasses only third degree and fourth degree tears. If there is any doubt in classification of the third degree tear, classify it to the higher one. Now, identification of internal anal sphincter may be difficult at times because it is seen as a very pale, fibrous pink structure. Some few persons say that this is seen as chicken red, and external anal sphincter is seen as chicken red, and this is as a bright red. But while the patient is bleeding, it is definitely difficult to identify. Hence, the positioning, the lighting, and the proper instruments in place have a very helpful mechanism in diagnosing. So here we know this is the 3A, 3B, wherein if the external anal sphincter is affected in less than 50%, it is A, more than 50% B. Internal anal sphincter being affected is 3C, and if the rectoanal mucosa is affected, it's a grade 4 degree injury. Now this is a rectal buttonhole tear with an intact sphincter. So only a digital examination of rectum can identify. Now repair of OSE preferably should be done by a trained clinician in OTs. All these I have spoken. Figure of 8 sutures are to be avoided, especially while repairing of anorectal mucosa. Now how do we repair the external anal sphincter? We identify the ends, and it is done after identifying them. It is held by Alice clamps, mobilize them if required, so that if we are doing an overlapping, if the full thickness of external anal sphincter is gone, then we can do an overlapping technique, or else end-to-end repair can be done even in partial thickness external anal sphincter injury. Now here we can see, so few mattress sutures are placed in end-to-end anastomosis, end-to-end joining, and that's an overlapping suture where double breasting is being done. But remember, overlapping is only done in a higher degree of injury, where the whole thickness of external sphincter is gone. Okay, now coming to this is the procedure which has been advocated while repairing of external anal suture. First, how do I show? First, it starts with placing a suture at posteriorly, then we come down, that is inferior suture which is placed, a simple suture, then we go through the muscle and place a figure of 8 suture in the muscle, then an anterior suture followed by a posterior suture. So here we are placing regenerating the entire complex, and the strength of the closure is derived not from the striated muscle but from the connective tissue surrounding it, which is also known as the capsule, so that the incontinence mechanism, there is no way that it will give way. And what are the suture materials we use? Of course, we use an 3-0 vicryl with, in case of a 4th degree tear. For an anal mucosa, we use, the guidelines say to use a 3-0 vicryl suture. 3-0 PDS also can be used in a running or a intermittent, as such you can like. But in anal mucosa, remember, do not use figure of 8 sutures. Next, for internal anal sphincter, it is identified, and we use a 2-0 vicryl suture to approximate using simple interrupted sutures in an end-to-end fashion. Now this brings us to the summary. The torn mucosa is repaired using a running stitch. The internal interrupted sutures are also acceptable. Internal sphincter is repaired as a separate layer. External sphincter is then identified and repaired. Either it consists of end-to-end anastomosis or an overlapping technique. Okay, now we come to the prevention. Now, primary prevention, obviously, this is not much advocated. There have been no RCT trials for advocating an elective cesarean section. Now, coming to the secondary prevention, these are the modifiable risk factors. The most important of it is perineal protection measures, the way we deliver. So, the fundal push method is out of the scene now, no more advocated. Spontaneous over instrumental, vacuum over forceps, restrictive or selective episiotomy as to a routine episiotomy, mediolateral, not midline, antenatal and intrapartum perineal massage may help, intrapartum warm packs, birthing positions, Kegels exercises. All these are preventable measures. Now here, this is providing manual perineal protection in the normal semi-recumbent position. Here the dominant hand, the thumb and the index finger, they are separating the labia, and the other 3 fingers, they will be supporting the perineum or the perineal body. The non-dominant hand is used to cup the head, and the mother is asked to push in between the contractions, take deep breaths between, relax, and the non-dominant hand is guiding the speed of the delivery of the head till crowning, till the restitution occurs, and then the shoulders are bone. I'm sorry, the video is not there. Now, here is the perineal protection which is given in lateral birthing position. Similarly, even in all 4 positions, here the non-dominant hand is placed above, whereas the cupping of the head is down. Now, while using a ventus, if there's a single person, if you don't have 2 surgeons or an assistant, then the dominant hand will give the perineal support and non-dominant hand is using the vacuum. In forceps delivery also, usually it is advisable to have 2 persons so that one is giving the support, perineal protection, and the other surgeon, the main surgeon, is applying the forceps. Now another, of course, coming to episiotomy. See, restrictive versus routine has been, I have told, and an angle of 60 degrees away from midline. It is during crowning to be given. If we give it before, then the angle may be less. Like a episiotomy which is performed at 45 degrees will result in post-delivery angle of 22 degrees. So a 60-degree episiotomy will result in a post-delivery angle of 45 degrees. And very recently, there is a epi scissors which is available in the market, which has a 60-degree angulation. Now, these are the methods of preventing OSS by giving warm compresses. Now, how do we manage post-operatively after a repair has been done? Of course, the use of broad-spectrum antibiotics is recommended, and of laxatives also around at least up to 10 days. Bulking agents are not to be given routinely, and local protocols should be implemented regarding the use of antibiotics, laxatives, examination and follow-up of women with obstetric anal sphincter repair. Women can be advised physiotherapy also, and those who have undergone an OAC should be reviewed at a convenient time, that is 6 to 12 weeks postpartum. If a woman is experiencing incontinence or pain at follow-up, referral to a specialist gynecologist or colorectal surgeon should be considered. Now, these are the tertiary prevention strategies, like wherein we will advise cesarean section for women after corrective continence or reconstructive surgery, for symptomatic women with clinically evident anal sphincter defect, for asymptomatic women with clinical evidence of anal sphincter defects, and for asymptomatic women with previous history of 3rd or 4th degree perineal laceration. Now, just last 2 slides regarding OAC care bundle. It was formulated by RCOG and Royal College of Midwives. They have advocated 4 steps, that is, inform women about OAC and what steps can be taken antenatally to minimize her risk. When indicated, episiotomy should be performed mediolaterally at 60-degree angle. Documented use of manual perineal protection. Perineal examination using a per-rectal examination is to be carried out following all vaginal births. So to summarize, rates of OAC is definitely increasing. It cannot be zero, but of course we should ensure during repair internal anal sphincter is to be repaired end to end, full length of external anal sphincter is to be repaired, and overlap is to be done only in full thickness. And OAC can be minimized by using a episiotomy at 60 degrees, perineal protection, use of vent-use, and OAC care bundle. Occurrence of OAC is in substandard care, but missing or failing to identify OAC definitely amounts to medical negligence. A poor technique, poor material selection, poor healing may cause a repair to fail. So with these words, I would like to conclude. Thank you.
Thank you, Dr. Samita, for your informative lecture.